So today my topic is Varicella-Zoster infection. Lifelong, as you are going to be a doctor, you have to deal patients, whichever subject you go, whether you go surgery, whether you go gynecology, whether you go medicine, all subject you need this subject, you have to deal these patients. So that's very important for your whole life. And number two, this is very important for your theory questions. This question come in the medicine also, not only in derma. In medicine, sometimes give long question on this particular topic. And number three, this is very important for your multiple choice MCQ questions for NEET entrance. So each and every point is very important. And if you don't understand any point, you raise the hand. And if you don't understand anything in English, let me know, I will tell in Bengali, no problem. Just tell me that I cannot understand. You raise your hand and I will again explain. So this will divide the subject: introduction, the virus, the pathogenesis, the epidemiology, clinical features, differential diagnosis and the laboratory diagnosis. Management is definitely in any disease very important. And last one is the vaccination. Last but not the least, this is very important nowadays because we can do vaccination in this disease. Now this is a spectral disease. What is spectral disease? One side there is no immunity. There is no immunity in this varicella. This is the chickenpox. No immunity in the body. First attack of the virus, that is the varicella. And this one end we have this herpes-zoster. Here is some immunity of the body. In between you can get breakthrough varicella and disseminated herpes-zoster. So you know any other spectral disease in medicine? One side same virus, but when there is no immunity we are getting chickenpox, and when there is immunity we are getting herpes-zoster in late age. So any spectral disease do you know? Have you heard leprosy? You have read leprosy? So leprosy is similar spectral disease. One side tuberculoid leprosy, that is the patient has immunity, and another side there is lepromatous leprosy, so there is no immunity. So these are called spectral. Immunity wise the disease pattern changes. Now this is a disease where lot of morbidities, patient get lot of suffering, lot of pains. So you have to do prompt treatment in this disease. And next, pain I told, especially herpes-zoster is a very painful. Have you seen any case of herpes-zoster in your life, in your surroundings? Anybody? Herpes-zoster not seen. Definitely you see, even in your some friends, some relatives, you can get this. And next, first, this is a treatable disease. You can prevent the disease. So you must know, must learn the disease. So you can treat the suffering, you can prevent the pain. Now this is a member of herpes virus family. So this is the virus, and this is a large DNA virus. So you know two types of virus, one is DNA virus, one is RNA virus. So can you name one RNA virus which can cause a very important disease, RNA virus? Yes? Yes, very good, very good. That you must remember, RNA is a HIV disease and this is a DNA virus. Now the characteristics of this infection, once it is the infection in your body, it persists throughout the life, never eliminated from the body, and it comes as a latent infection. It persists as a latent infection, and if the immunity is depressed for any reason in the body, then it can come up as a again reactivation of the disease. So that is latent infection could be reactivated. Is it clear? Am I clear? If you don't understand, you please raise your hand. You should have clear conception, then you can write well. Now these are the different type of human herpes virus. First one is a human herpes simplex, that is herpes labialis. Have you seen herpes labialis? Yes, definitely. Yes. Tell me please what you are telling. Actually, this is all you have seen. In Bengali, it is called jot tuto. Jot tuto, it is the herpes simplex or herpes labialis. So, that is the herpes virus 1. Next 2 is herpes genitalis. That is a sexually acquired infection, very common disease nowadays. And but this can be reversed. HIV 1 can cause this genital herpes, or 2 can cause herpes labialis. And next one, the 3 what we are dealing today, that is a chickenpox or herpes zoster, infectious mononucleosis and Burkitt lymphoma. 5 that is a CMV, that is cytomegalovirus retinitis. Then 6 is a roseola infantum, this is pediatric disease, and 7 is one our skin disease, that is Pityriasis rosea, and that 8 is important, that is Kaposi's sarcoma. Kaposi's sarcoma is usually associated with, yes, HIV. But Kaposi's sarcoma can come on its own without HIV, but sometime it may be associated with HIV. Good. Now, primary infection, when first attack in the body, there is a chickenpox or varicella, usually in the early age or younger age. But then a latency period, long latency period. Then ultimately reactivation, that is the herpes zoster. Usually it is a late age. Now, how the varicella, this is important. If you know this, then less reading of the book. First, the virus is going in the body, to the actually this droplet infection. Through droplet airborne infection, virus entering into the mucosa, and then it is residing in this nasal mucosa. Then first viremia. What is viremia? Virus circulating in the blood. So this is the first viremia, primary viremia, first 7 days. But that time no rash. Then then it is ultimately lodging some internal viscera like liver, spleen, etc. And then from there to secondary viremia. Second time again viremia. And after that the rash going to the skin. So from second viremia, the skin eruption is taking place. So this is important. 7 days primary viremia, and then second viremia is 7 days. So ultimately 14 days is the incubation period. Once it takes entry, after 2 weeks we get the rash. It is the incubation period. Now, how the herpes zoster is taking place? When virus, first chickenpox is appearing in the body, some of the virus are taken up by the sensory nerve endings, and that going centripetally. What is centripetal? Outside to inwards. Very good. Centripetal. What is centrifugal? Just opposite, outside, towards outside. So it is going centripetally to the sensory dorsal ganglia. So then the ganglia, it is persisting. Where the virus is persisting? Virus is persisting as a latent infection for whole life. Whole life. Once you have chickenpox, the virus is persisting for whole life. Now, where it is coming, usually the chickenpox is appearing in many parts of the body, but where it is more rashes, usually that part, that dermatome. What is dermatome? Yes, dermatome. Yes, please louder. Dermatome. Single spinal nerve. One area of the skin supplied by single spinal nerve, that is called dermatome. So there are different dermatomes in our body, thoracic, cervical, different L1, L2, etc., C1, C2. So this dermatome, where the virus was more affecting, there it is coming more. But sometimes after that reactivation may occur, but always we are not getting herpes zoster. When it can happen? It can happen when the critical levels flow, critical levels of the immunity level falls, then only you can get the herpes zoster. So this is very important disease, interesting disease, that this is a host virus interaction, because when your body immunity falls, then you can get this herpes zoster. I can have in my dorsal ganglia, because I had chickenpox in my childhood, but I am not getting it, though I have taken the vaccine, but still I am not getting it up till now. So reason is that critical levels is not falling. Now these are different dermatomes I took: thoracic, cervical, trigeminal, that is ophthalmic, and lumbosacral. But as we are getting older, chances of ophthalmic chances is more. The thoracic is commonest, but as the age advances, chances of this ophthalmic zoster increases more. So these can come your MCQ. This is what is the commonest dermatome at age advances, which is the commonest dermatome affected. Now, who will get herpes zoster? That's the important question. Normally, younger age not having, though it can happen. In medicine, nothing is impossible. It can happen. But here, as the age is advancing, it is called immunosenescence. You remember the word immunosenescence. What is immunosenescence? It is a normal decline or normal falling of the immunity due to age, not for any disease, not for any drugs. It is a normal decline. As the age advances, immunity decreases, and that is called immunosenescence. But in other cases, before the normal age, it can happen in immunocompromised, like malignancy, this immunocompromised, immunosuppression. It can happen in HIV, that is an immunocompromised disease, and also therapeutic immune suppression, like if the patient is taken steroids or other immunosuppressing drugs. But you remember, we have seen cases in the younger age group also. That's not rare, but we are definitely less than the adult age group. Now, as I told, this is important, that first we are getting the varicella, then ultimately it is coming down, the immunity is coming down. After 50, immunity is low. So you can get herpes zoster in this age. And this time if you take vaccine, now vaccine is available in India, zoster vaccine. So again your immunity is boosted up. So this is important, how you can boost up your immunity. So this is, herpes zoster is one of the most painful condition of the body. If you see one case of herpes zoster, especially adult aged patient, you can know the pain. So how the pain is happening? This is the dorsal root ganglion. This is the actually virus is staying. From that it is going to the skin, and this is the actually ascending and descending spinothalamic tract. So this pain is carried to the central nervous system for appreciation of the pain. So this is the important. Now profuse excitatory amino acids and neuropeptides are liberated during the infection, and that is ultimately causing damage to the neuron and the ganglion where the virus is persisting. Now this is the epidemiology. One is after vaccine. Chickenpox vaccine is available since 95 in US, and India it came 2000 onwards. So before that chickenpox was much commoner. Now we are giving vaccine to the children, so we are getting less chickenpox, and if it happens it is very less amount. So that is 90 millions. And household transmission, if one person is affected in chickenpox, usually whole household are affected. So that transmission is 80 to 90%. And second case is always severe. I remember when in the childhood I had chickenpox, my cousin, we are joint family, my cousin brother was first affected. His chickenpox was not that severe. I got the second man. So it was profuse chickenpox I suffered. That time I was first year MBBS student. So I actually refrained from class about 2-3 weeks. So that is a problematic condition. But now children are getting vaccine for chickenpox. So chances are less. If it happens, it is less amount. Now US hospitalizations was 11,000. This is a pre-vaccine, when the vaccine was not innovated. And immunocompromised patient, actually this could be a prolonged eruption, because immunity is very much related to this disease. Now, how this is going from one person to other? Mostly it is airborne, I told, it's a respiratory tract infection, and direct contact from one person to one can happen. But this is very important. You should also learn, because this is a very common belief. Even some doctors believe that crusts are infectious. Not at all, not at all. No crust until the crust happens after the, you understand what is crust? After the drying up, the crust, these people, common people think, or some doctors think that this is very infectious. Not at all. This is not infectious. That stage you can mix with the patient. Not infection. And you can allow the patient to go his job. Now, chickenpox is a seasonal disease. Usually it is a spring. That's why in Bengali it is called Bosonto. But it can happen in other time also. But this is seasonal. And actually the herpes-zoster cannot go from one person to other. And one thing very important, that herpes-zoster today I cannot infect herpes-zoster to you. If you are already not having chickenpox in your life, today if I have herpes-zoster, if you are contact with me, you will get chickenpox, not herpes-zoster. Be clear in this idea. If you have no immunity, you first get not herpes-zoster. You will first get chickenpox from one herpes-zoster patient. And actually I told it is a host-viral relationship. That's very important. And risk factor, who can get herpes-zoster? Older age, above 50 is very involved, because that's why now vaccine. Now herpes-zoster last 3-4 years vaccines are available in our country. We are using in our patients. 50 above it is recommended. Now herpes-zoster virus, Shingrix that is called, that is now recommended 50 years above, not below that. But in their country it is lower age also. And if cell-mediated immunity is disturbed like HIV, which type of immunity? Two types of immunity. One is humoral, one is cell-mediated. In this disease, cell-mediated is more important, not the humoral. So HIV due to CMI depressed, so it's more chances of this herpes-zoster. And if the spinal cord is irradiated from malignancy or some tumor or some trauma on the spinal cord, if some chot laglo kono patient, then he can have herpes-zoster. Your trauma on the spinal, dorsal ganglia, now reactivated, the virus coming in the skin. And if you do surgery in the spine, it can happen. And also the frontal sinusitis some people do have, they may precipitate also this ophthalmic zoster. Now this herpes-zoster contagious, but less contagious that because chickenpox, varicella is a whole body affair. And up to 7 days from the appearance of the rash, virus can be isolated. Up to that it is infectious. And this is herpes-zoster, it can direct infectious and also direct and droplet. Now I told fast viremia, the first 7 days, there is no rash, but there is some prodrome. It is any viral infection, there is some prodrome. That means some headache, some fever, that can happen. And number 2, this second viremia, we are getting the rash. And this rash could be profuse, 250 to 500 rashes, vesicles. As you know these things, some basic terminology of dermatology. This is called vesicle, this is called papule, this is called pustule. You know this. You must go to your book, any medicine or dermatology book, you must learn. As we have in our alphabet, A, B, C, D, we know English, O, K, K in Bengali. Exactly, dermatology, we have certain terminology like papule. Papules means solid, elevation less than 1 centimeter. Vesicle means fluid filled, elevation less than 1 centimeter. If papule more than 1 centimeter, we call plaque. If vesicle more than 1 centimeter, we call bulla. So these are important terminology. In this way we describe. So here this is vesicles. In herpes-zoster you won't get papule, you will get vesicles. And how is the stage? First you get this papule, then vesicle, then pustule, ultimately pustule. Pustules means the vesicle now turned into pus, that is pustule, not clear. Vesicle is a clear, and then crust, ultimately crust. And this, what is the classical description? If you want to diagnose one case of chickenpox, the classical description is that if you once, yes, tell me. Yes, it's very good, very good. That is a dew drop, just shishir, is a poetic language, on a rose petal. Mane erythema means redness. Redness of the skin, on top of that, a simple vesicle. Vesicles is a clear fluid, just like a deer drop or teardrop. And so another important is that this varicella you will get in a patient, today if I say second day or third day of the patient, we can see vesicle, we can see pustule, we can say second day you won't get pustule, fourth day or fifth day, but you can get also papule. So these are different stages of lesion you can get in chickenpox. But another disease, you know, this is very closely nowadays not happening. Yes, very good. So smallpox, you know, is eradicated 1985. WHO has declared the smallpox has been eradicated. But can you tell that smallpox can still happen in anywhere in the world? Can happen anywhere. How? Bolo. Good. Bolo, is it louder? Virus are kept in? Yes, good. It is kept in as a laboratory, as a experimental. How it can go? Biological ward, you know that. Biological ward, you ready for your exam. Biological ward is important. That time some country can send this virus to another country. This smallpox virus in this way can spread again in world. So this is biological war. Many other viruses are also there, but this smallpox is one important of them. So, but smallpox in our student life we are taught. The difference is one stage you will get one only vesicle, no papule. This is a difference. But small chickenpox, nowadays you are not to learn this because you are not dealing smallpox, but in our student life we had to deal. That time it was still there, few but was there. So vesicle, only vesicle in a small. And another important that the lesions that I told teardrop or dewdrop, that is drying from the center. So that's why if you see with a lens, you will say a umbilication. You know umbilicus. So in the vesicle, you will see a center dipping. That is the umbilication. And these lesions are centripetal. Again, very important point. Centripetal. That means chickenpox you will most get in the axilla, in the trunk, not hands on feet. But smallpox were more common in the hands feet. That is centrifugal. And sometimes you may get normally 7-10 days it is drying up. But if you see 2 weeks, 3 weeks going on, whether herpes-zoster or chickenpox, what you will doubt? You doubt there could be some secondary infection or there could be some immunity depressed. So if the immunity is depressed, it can prolong for a long time. Now fever is usually associated with low grade fever, only few days. But if you see fever is going on for a long time, chickenpox, then you can suspect again some infection or some immunity depression. This is the whether you can see from the distance. This is the actually the red area. Here the projection is not very clear. This is you see, this clearly you see, this is the actually the vesicle, teardrop, and that is the row on the rose petal. There is a petal that is a red base, and this is the dewdrops. And central through lens you will get a central puncta, that is the umbilication. So this is you have to diagnose. If you can't diagnose, whether you are a surgeon or gynecologist or say physician, if you can't diagnose chickenpox in your family or in your surrounding, you will be treated as a veterinary doctor, not a normal doctor. So be careful, chickenpox you must diagnose. This is not a dermatologist's job, any physician should diagnose this. This is the adult varicella. Adult chickenpox is very important, very important. I am coming later. And these are adult chickenpox. Normally chickenpox happening in the early age, but in some case you can get adult chickenpox. That is important why I am coming. This is adult chickenpox. Now clinical features, it can happen in the inside, that is called any viral infection, they have external on the skin, that is called exanthem. Or if it is outside inside, that is called enanthem. Any viral infection, sometimes not only chickenpox, inside mouth, that is called enanthem, and external is called exanthem. So you can get this, and here chickenpox you won't get eye lesion, but smallpox, that is called variola, had very common eye involvement, and many patients before 80s have lost eyes due to smallpox. And this lesion is usually, I told, cast within 7 to 10 days, but prolonged eruption, again immunity, loss of immunity or secondary infection. This is enanthem, you clearly see, this is the actually enanthem. In chickenpox you will get within these oropharynx these lesions. Now one interesting point, nowadays we are giving vaccine to almost all child, those who can afford. But one patient, when a child patient with her mother come to you when you are doing practice, you have given vaccine to my child, but still chickenpox happens. What you have done? They can challenge you. What you have done? You have given vaccine, still chickenpox happened. So what is this? How will guard yourself or how will explain yourself? The vaccine of chickenpox is not 100% protective. That is 80 to 90% protective. So you tell the patient that it can happen. Even during vaccination, when you give the vaccination, you tell that it is not 100% protective. Some patient may get chickenpox, but it won't be severe. It will be mild. So only reassure the patient's parents. That's your duty. Not always give treatment. And here no need of any giving antivirals. Understood? So this is called breakthrough varicella. In spite of vaccination, some child may get few eruption, that I am showing, few eruption, very few. So, and even fever, another thing not. So this is called breakthrough varicella. So this is term you must know, because nowadays we are giving vaccination, some patient can develop. So this is breakthrough varicella, only few. So tell the patient, tell the parents that is nothing to do, just rest assured. Now what are the complications of chickenpox? First is the cellulitis, infection. Any chickenpox is a viral infection. On top of that you can get bacterial infection. Next, pneumonia. This is a very important side effect of adult chickenpox. You must learn throughout life that chickenpox today, adult patients, particularly smoker, you should be careful about this. I remember when I was in another medical college before this, one of my postgraduate students one day came and he told me that yesterday he saw a case, chickenpox for 5-7 days, and suddenly having breathing difficulty, dyspnea, and came to the emergency, not dermatology, emergency, severe dyspnea. And that patient, they tried all their best, but ultimately within 3-4 hours, patient succumbed and died. So this very careful, any chickenpox patient comes to you with dyspnea, especially adult chickenpox, especially smoker, you should try your best in admission. You must admit the patient. You don't take casually. And very interestingly, if you auscultate the chest, you won't get many findings. You won't get. Patient will complain severe dyspnea. You can think it is a psychological, not that. Not psychological. Out of proportion breathing difficulty. And this adult pneumonia, chickenpox, a very serious complication of chickenpox. This you don't miss. And certain neurological complication can happen, but that's a bit rare. And this is the, if you see, after the crust is happening, after that certain, you see red halo, it is not the rose petal, it is the later age is redness after crusting happening. This is not the rose petal, it is actually the secondary infection. and patient may have fever. So these patients you immediately start antibiotic. You give for culture but don't wait for that because chickenpox depresses our immunity. So if any infection happens, it can be a serious thing. So immediate start antibiotic. And this is I was talking about the varicella pneumonia, that is adult chickenpox pneumonia. And the common sufferer are smokers. Cough, dyspnea, tachypnea. What is tachypnea? Increase? Increase? Yes. And number 2, here how can you diagnose? Auscultation won't tell nothing. So you can do a X-ray of the chest, that's must. And X-ray of the chest you will get, you will get this X-ray of the chest is very important. You will get this diffuse peribronchial nodular density throughout the lungs and perihilar and basis. This is a very diagnostic feature. And here the mortality, if the patient is immunosuppressed, it could be even 30%, a normal 10%. So very careful about this disease. What is Reye syndrome? Have you heard of anything? No. Yes. Who will tell? Reye syndrome? Yes, bolo. Yes, what? Jode, हाँ. বাচ্চাদের বেশি হয়, very good. Next, কি হয়? Yes, good, partially good. Actually, this is also complication of not only chickenpox, any viral infection. It can happen about influenza, but most commonly happen if you give aspirin. Never give aspirin to a chickenpox patient. You write in your prescription, don't take aspirin because patients are very commonly taking their own aspirin, disprin, etc. So if they take aspirin, chances of Reye syndrome more, usually in the child, but it can happen in adults, and it is hepatic, actually encephalopathy, acute encephalopathy with fatty degeneration of liver. So Reye syndrome mostly happening from aspirin, common in childhood, and especially chickenpox, why you never give aspirin, because patient may have pain. So write in your prescription, you should write for medical legally, because patient may take them themselves. So you avoid aspirin. Hemorrhagic, sometimes chickenpox, after that I have seen cases, after that purpura or hemorrhage. If you see, immediately admit the patient because it is a purpura, thrombocytopenic purpura can happen. And other certain complication, I am not going details. And in immunocompromised, chickenpox can do lots. If there is steroid, patient is on steroid for other reason. So that if by chance chickenpox attacks, it will be a very severe condition. And malignancy also, chickenpox could be a disaster. And immunocompromised like HIV patient get chickenpox, it will be disaster. Now first there is a prodromal, all like chickenpox, herpes-zoster. And it is unilateral, one side of the body, unilateral, because it is coming through one spinal nerve, and one dermatome, but it can happen bilateral anytime. It is unilateral for normal side. Herpes-zoster you diagnose is a unilateral lesion, but can it be bilateral? When I was intern long back, first after MBBS, I saw a herpes-zoster bilateral admitted in our medicine ward. The patient had Hodgkin's disease, lymphoma. So due to immunosuppression, it can be bilateral. That's a rare. Don't take first in mind. Never tell in the exam this is bilateral, this is unilateral. But rarest of the rarest, it can happen. And what is allodynia? If I touch you with a pin, you will definitely feel pain. But if I touch with a paper, you won't feel pain. You will just touch. But in this patient, allodynia means if I touch the patient's skin, herpes-zoster, he will feel pain. Even with a paper, he will feel pain. There is a minimum sensation cause pain. Now this is another very important. Herpes-zoster, first few days, no rash, only pain. Only pain. So this can, say one chest pain, today, this is very common in our practice. Chest pain, patient was admitted in the intensive cardiac unit as a diagnosis of myocardial infarction. ECG, nothing. After 5 days, the rashes is coming. Same thing can happen in the abdomen, abdominal pain, no rash. the surgeon can think it could be a acute cholecystitis, or it could be acute appendicitis or something else. So first, when there is no rash, patient can be misdiagnosed. A few weeks back I got a patient, a severe pain, the patient was admitted in a chest ward, but they got nothing, and after 4 days they released, and then patient is coming to me with a herpes zoster rash. So first few days this could be misdiagnosed like anything. Now the chickenpox rash is generalized whole body and is very rapidly spreading, but herpes zoster is very slowly spreading, because the herpes zoster is spreading through nerves, but chickenpox is spreading through blood, viremia. So that's why the difference. Now another I told herpes simplex. Herpes simplex and herpes zoster, what will be the difference? What could be the difference? That is the cause, but clinically how will distinguish? Clinically how will distinguish? Herpes zoster, anybody? Herpes simplex and herpes zoster, the virus are different. That is 1 or 2 and this is actually 3. But actually how we can get the difference, clinical difference? You have to get the difference. The word herpes means grouping. The word means grouping, the group vesicles. The basic word is group vesicle. In herpes zoster, group vesicles. In herpes simplex, you will group vesicles. But that is localized to one area. But in case of herpes zoster, what is the meaning of zoster? It's a Latin word, it means a belt. So it is coming as a dermatome, is a belt like, but herpes simplex won't be there. Herpes simplex won't be there. Herpes simplex is 1 or 2 grouped area, not as a dermatomal distribution, not a belt like. So that is the basic difference between herpes. And herpes simplex is recurrent. It can happen not only in the lips, it can happen anywhere in the body, but it can recurrent. Very commonly it can recur every month or 2 months like that. But herpes zoster usually in normal immunity patient is usually once. Okay, so that is the basic difference. And this is the day 2, the only vesicle of herpes zoster. In a dermatomal pattern, you can see that one dermatomal pattern. This is a day 3, day vesicles. This is a day 6, some had already dried up, fewer still vesicles. And this is the day 8, almost crusted. So when the patient will ask you that give me some certificate so that I can join my office or children my school, when and give the certificate? When the last vesicle dried up, whether chickenpox, whether herpes zoster, last vesicle dried up. But there is again common mistake, some doctors give leave for 1 month until the crust are falling off. This is not necessary. This is absolutely wrong. When the vesicles are all dried up, no vesicles are coming, you give certificate. This is very common in your future practice. You have to, anybody will ask you the certificate to join, because it is infectious disease, patient can't join. So after that they will want certificate from you. So this is very clear that when the vesicles are dried, you can tell them to join. And trigeminal nerve, this is the most important affected area. First is ophthalmic, I am coming later. Maxillary division, you will get the vesicles uvula and tonsillar area. Mandible, you will get the anterior part of the trunk, you will get the vesicle, it is a mandibular. And sometimes this orofacial zoster can report to a dental surgeon, his pain in the toothache, but it is actually pre-eruptive stage of herpes zoster. Ophthalmic zoster, that is the most important complication of herpes zoster. You, whenever again I am telling any subject you take in your future, you don't forget this. This is from the level of the eye to vertex, and it is sharply demiling. If you see a case, sharp demarcation at the midline. It is not bilateral. And if the supratrochlear or supraorbital nerves are involved, I am showing picture, then eyes are less chance of affected. Because eye involved, eye could be lost. Very careful. And if it is nasociliary branches involved, that is called Hutchinson sign. Very important. Hutchinson sign, I am showing picture. then chances of eye, you definitely refer to eye specialist. You definitely. Otherwise, you will be sued. Patient can do case against you if you miss this. I remember one case, one herpes-zoster, I saw this case and I referred to eye specialist, but the eye specialist was not very serious. So ultimately the eye was damaged and they sued against the eye specialist. So very important. And ocular, all sorts of complication can happen. Retinal necrosis and eye, everything, blindness, total blindness, it can happen. And this is, you see, actually this is the supratrochlear and the supraorbital nerves are involved, so no eye affected. And this is the Hutchinson sign. What is Hutchinson sign? Tip of the nose and lateral side of the nose, you will get vesicles. You must look. If you see the trigeminal nerve, yes? Now, half of the nose, not necessarily, but it can have tip of the nose. You can have vesicles surrounding. But if you see tip of the nose, vesicles and side of the nose, then definitely Hutchinson sign positive. Then eye involvement very common, and you must refer, must refer. Otherwise, the patient can have eye damage. And this is, I told about eye, this is another case, this is a ear. I remember one case, she was a lady, she was an anchor in TV, famous. She came to me when I saw vesicles on the external ear and some ear pain. So that is herpes-zoster oticus. I referred to an ENT specialist. Again, the ENT specialist saw but didn't give not much medicine, and after 4 days the patient came. The lady came with facial palsy. So if you see vesicles external ear, the patient can develop this is called Ramsay hand syndrome. This is facial palsy, ear pain and the vesicles. And another very dreadful complication of herpes-zoster is postherpetic neuralgia. If you see one case in your life, you remember that case. Previously, when we were students, there was no antiviral available, no vaccine available. So we saw a lot of such cases. Now, fortunately, less. But if you don't give antiviral to a particular herpes-zoster patient, in an aged patient, the patient can develop this postherpetic neuralgia. Is almost the patient, somebody is stabbing him or stabbing her with sharp knife repeatedly. So this is, so patient can't, his life quality is totally hampered, he can't sleep. So this is a very dreadful complications. You remember when the vaccine came first 4 years back, then Amitabh Bachchan gave this advertisement in the TVs and all the papers about this postherpetic neuralgia, that please take the vaccine, otherwise you can develop this, in this name, postherpetic neuralgia. He was their brand ambassador of this company, GSK, the Glaxo. And disseminated herpes-zoster is rare. If you see herpes-zoster is disseminating like chickenpox, then you think definitely some immune suppression. Definitely some immune suppression. And postherpetic neuralgia, when we will tell any herpes is associated pain, that is not postherpetic neuralgia. When after the herpes-zoster is almost controlled, after 3 months, patient is still having severe pain, then by definition is postherpetic neuralgia. So if it is come in your MCQ, postherpetic neuralgia, you remember the deadline is 3 months, not before that. And who are aged person more having chance? Ophthalmic zoster more chance. If the patient has severe pain from the beginning, more chance. So postherpetic neuralgia is a very dreadful complication. Now immunocompromised patient, herpes-zoster could be a different situation. There I told one case in Hodgkin disease I saw in my internship, that is a bilateral, it can happen, multi-dermatomal can happen. You will see herpes-zoster different areas. So definitely there are chances of, I remember one case, one young, about 30 years old man came to me with herpes-zoster, but after 3 weeks, in spite of antiviral, still developing rashes, still. After months, still having herpes-zoster. So I searched whole body, blood test, everything done, nothing we got. But after 3 months, one of my neurosurgeon friend, while we are coming through lift from my hospital, he told me that your patient have seminoma testis. He was undescendant tested that turned into malignancy. Very chance of going to undescended chance in adult life, it can turn into malignancy. So that's why the patient have herpes zoster so prolonged after a month. So that was a hidden malignancy. Patient was not aware of. We searched, but fortunately after 3 months he have gone to the neurosurgeon. It was detected. And this is a patient herpes zoster wrongfully some doctor gave steroid. So that's why the charge, you see, it is not at now grouped. It is almost a generalized becoming. Now this also keep in mind. Normally sensory part is involved, sensory nerve, because it is the sensory nerve. But sometimes motor paralysis can happen after herpes zoster. Motor palsy can happen. This you also keep in mind. Sometimes facial palsy, I told one case, facial palsy can happen. And also this anogenital, some patient may develop hernia or disturbed micturition, discharge defecation, this can happen. And this is another very, very important topic you must know, because this is not only for, it is also for pediatric and also for the gynecologist. If chickenpox happens in pregnant woman, what will happen? It can have maternal pneumonia. Patient may die sometime. The adult chickenpox, the mother can die. And next is a congenital varicella syndrome. You know congenital varicella syndrome? Any idea congenital varicella syndrome? First 20 weeks, if a pregnant lady gets chickenpox, the baby can be affected. So that could be a lot of congenital anomalies. So you ask the mother to abort the baby, because that baby would not be a normal baby if first 20 weeks. Or number 3 is if the patient neonatal chickenpox, that means during delivery 1 week before after, if the mother gets chickenpox, then what will happen to the baby? The baby will get chickenpox because he has not got the immunity from the mother. If 2 weeks before, 3 weeks before delivery, mother will acquire the infection, antibody. So he won't get chickenpox. But if 1 week before after, he is not acquiring the immunity, so he will get chickenpox. And this neonatal chickenpox is a very dreadful. The baby can die. So if you are a gynecologist, you have to diagnose. You have a pediatrician, you have to diagnose. So this is a subject for all this domain. Congenital varicella syndrome, I told before 20 weeks if it happens, lot of complication, intubated, growth retardation, microcephaly, limb fibrosis. So you have to counsel the patient, counsel the mother that you should abort. Otherwise it will be a deformed baby. And if it late pregnancy, actually the mother can have premature labor or neonatal infection, but usually baby is not. If 20 weeks after, this can come in your MCQ. 22 weeks pregnant lady having chickenpox, you will ask to abort? No. Before 20 weeks you should ask. And this neonatal varicella I told is a very dreadful. Sometimes patient can die due to, again, this is the pneumonia. And here the treatment, not only antivirals, you have to give immunoglobulin. Neonatal, they have no immunity. Baby has no immunity, not acquired any immunity from the mother. So you have to give this. And this is an interesting. You just think of a 4 months or 5 months or 6 months, a baby can have herpes zoster. Is it possible? I told without chickenpox you would never develop herpes zoster. So can a 6 months baby have herpes zoster? I have seen cases 6 months baby herpes zoster. No history of chickenpox. How can it possible? Acquired means how it is acquired? Yes, mother have chickenpox during the pregnancy. So from that baby has some partial immunity. So now if the infection is happening, that is herpes zoster. So I am not going details, but time is short. So this is a different hand, foot, mouth disease. Have you know this case? Very common in this rainy season. Very common. It is from fecal-oral route. It is very looking like chickenpox. Hand, foot are mostly commonly involved. So this is actually hand, foot, mouth disease, common differential diagnosis of chickenpox. And herpes zoster I told, and laboratory I am not going details. It is usually clinical diagnosis. Laboratory diagnosis is not required. And these 3 drugs you must know, you probably read in your pharmacology, acyclovir, valacyclovir and famciclovir. These are the 3 drugs we are using, and those I am not going details, in any book you will get it, but this is important. A child, say 5 years old child or 6 years old child having chickenpox, whether you will give antiviral or not. Some doctors believe that, pediatrician believe that we won't give because they have normal immunity, we won't give. But whether we will give or not. Actually in US it was first advocated that we should give, and in our country also we are giving. The reason is that very short duration, the child can go to school very quickly if you give antiviral. The infection from one person to other, like to parent, it is very cut short. So in this way you are cutting off the horizontal transmission. So you are ultimately doing good to the society. So better to give antiviral even as a child. And adolescent to must. If you don't give it, again case against you. If today you see an adult chickenpox, you don't give antiviral, then it is an offense. And if it goes to the court, you can't save yourself. So this is, remember, whole life, adult chickenpox you must give antiviral, must. And this is postherpetic neuralgia, again antiviral we are giving, so guess chance. Some patient we are triclase, cytocycline, antidepressant we are giving from the beginning, and these are different treatment. Nowadays we are giving gabapentin and this pregabalin for this neuralgia like other neuralgia. Corticosteroid some old doctors give, but these are no role in postherpetic neuralgia, so don't give corticosteroid, oral steroid. Now chickenpox vaccination is now available last 20 years in our country. It is a live, actually it is an attenuated live vaccine, and it is safe and immunogenic, and usually it was 1 dose, and now they are recommending 2 doses, and adult always 2 doses. So chickenpox vaccine you must know. And number 2, this is a prevention of chickenpox. Immunoglobulin you have to give when the patient has less immunity. When not much immunity, you should give antiviral at the same time immunoglobulin. That is called Zoster immunoglobulin. Like a neonatal baby have varicella infection, there you have to give this immunoglobulin because you have no immunity along with antiviral. If a cancer patient, he was exposed to chickenpox, you have to give antiviral along with this immunoglobulins. Next is that this is actually, I told the baby just born without any immunity, you have to give immunoglobulin plus antivirals. And if a person is just say exposed to this herpes zoster, like this pregnant woman, so you give antiviral to this lady also. A pregnant lady exposed to a herpes patient or a chickenpox patient, you don't take the risk, you immediately give antiviral. And this is the latest development. Actually, this is the herpes zoster vaccine. This is a different vaccine. You must read this. This is now today the talk of the whole medical society. This is called Shingrix. Last 4 years after corona, it is available in India. We are giving, this is very important, above 50 years. Like you know, above 50 years, adult vaccination you heard. Adult vaccination, we are giving pneumonia vaccine, we are giving influenza vaccine, along with this herpes zoster vaccine. These are called adult vaccination. Nowadays, this is a very important, especially those who have comorbidities like diabetes, like hypertension, we should give this. And herpes zoster, not only a skin condition, it can give rise to even stroke. We have, after herpes zoster, some patient can have cerebral stroke. So this vaccine is preventable. And this is a dead virus. So this is not a live virus, attenuated live vaccine. This was a previous vaccine, Zostavax, now not available. The latest vaccine is this Shingrix. This is the actually adjuvanted inactivated virus. This is the latest virus. The previous vaccine now not available, obsolete. So this is the vaccine we are giving now, herpes zoster patient. But this is in our country above 50 years, not below that. and this particularly herpes zoster, having diabetes, having hypertension, we must give the vaccine. And this you must know, this is a CDC guideline of adult vaccination. Adult vaccination now is a talk of the day, so you must know the CDC guideline. This is very important. They are including the herpes zoster vaccine. So actually what I told, this disease you must learn because this is a substantial morbidity, you all understand. Number two, it is a preventable disease and it is a treatable disease. So many diseases we can't do anything, but this is not. This is a dreadful disease, but we can prevent and treat. So, and complications also we can prevent, that's important.